Hi MS Translators, welcome to a very special exclusive broadcast that we're running today on MStranslate, based on our understanding that it is a very different time in the world at the moment, and there are a lot of people living with MS, both in Australia and around the globe, that have many questions about how the current coronavirus COVID-19 pandemic will affect them. It's my pleasure to be joined today by a number of MS neurologists from the Royal Melbourne Hospital who have given up their time and an incredibly hectic schedule to be able to help answer your questions. And I have Thomas Kalinchik, Trevor Kilpatrick and Azan Ruse here with me today. So understanding that we do have quite a number of questions to get through, we'll be getting started very shortly. So if you're joining, welcome, and you can drop your questions in the comments box as we continue on. We already have a number of questions, so we may not be able to get through all of them today, but we will try and get through as many as possible. Just to reiterate the note that was in the event page, today we'll be answering general questions about MS and COVID-19. This isn't a forum where we'll be able to address specific health concerns for individuals, so we'll be keeping them at a very general level. So without further ado, we will get started. So I guess probably one of the biggest questions that we've received from the community so far is, as a person living with multiple sclerosis, am I at an increased risk of contracting COVID-19?
I think what we've learned is that there certainly are patient groups that are at increased risks of contracting COVID-19, and that would be older populations, people with heart and lung conditions and mobility issues. But being diagnosed with MS itself is not deemed to be an increased risk of contracting the infection. As we realize that there are parts of our MS community that do have these risk factors, however, so our older MS patients, those who have other comorbidities. But I think the big thing with patients with MS is the therapies that you're on. And that these therapies, whilst they don't necessarily increase your risk of contracting the virus, they might increase or change the way you're able to respond to the infection. The fact is that all therapies are not created equal, and we certainly have tiered therapies with different risks associated with them. And I think that's something that's very important for us to realize. So the first group of therapies are those that we would deem to have relatively low risk or low impact on your risk when you have contracted COVID-19, and those would be the injectable therapy, so the interferons, glatiramer acetate, perhaps something like teriflunomide, although we don't really know. And that's the thing that's difficult for many of you and us as well whilst treating you at this time, is that this is an evidence-free zone, and that we have basic ideas as to what the risks might be with any of these therapies, but we will have to keep an eye and see. So going back to the tiered response, the low-risk therapies are probably the interferons, glatiramer acetate, teriflunomide. Then we get another group of therapies, the other oral therapies, things like fingolimod or dimethyl fumarate. We need to remember that with these therapies, stopping therapy has its own risk associated with it. So if you were to suddenly stop a therapy such as fingolimod, that would increase your risk of reactivation or rebound disease, which might not be a risk that's completely offset by contracting COVID or your ability to fight this infection. And for that reason, we don't think that stopping fingolimod would be a wise choice in this case, and it might give you a moderately increased risk. Then we get the infusional therapies. So natalizumab is probably the safest of our high efficacy therapies when it comes to dealing with an infection such as COVID-19. There are various ways that we can alter how we give these infusions. There have been suggestions from other MS neurologists in the world that the infusions can be given 6 weekly instead of 4 weekly, although this is not a blanket approach and would need to be individualized in each person based on their individual characteristics. Other infusions such as ocrelizumab are generally given 6 monthly. We know that this does have a marked immune response and would have a moderate effect on your risk in this current epidemic. But fortunately, what we do know is that the duration of efficacy of B-cell therapies such as ocrelizumab is certainly much longer than 6 months. And for that reason, it can be safely extended perhaps to 9 months and perhaps longer with some monitoring. And that is certainly the type of approach we would be taking in patients. Once again, this will be individualized and will not be appropriate for each person depending on their MS risk as well as their current disease profile.
I guess before we go on to talk about the tailoring of the treatments, can we just mention briefly the level of evidence that we presently have for these things that we're telling you? The COVID-19 infection is still fairly rare infection in most geographical areas, fortunately. Multiple sclerosis is a fairly rare disease, ranging in its prevalence from 30 patients per 100,000 to 170 patients per 100,000 population. So you could imagine that these two diseases happening in the same person is a fairly rare occurrence.
And I think there's another important point in that context as well. And most of the experience to date has been in China, where there isn't the availability of the spectrum of therapies that we have available in Australia. And in fact, we'll probably be learning a little bit more about some of the therapies and their risks in the next few weeks as what evolves in Europe comes to bear, basically. So we have to be very clear that some of this is an evidence-free zone at this point of time with respect to some of the therapies that we are dealing with.
Yeah. So Trevor, perhaps would you like to expand more on what we have started to discuss? How should people be changing the way they receive treatments for MS?
Right, well perhaps I can backtrack to some really important points that Zan has mentioned. We've talked about evidence and that that's an evolving area. We really don't have all the facts in front of us at the moment, and that relates to specific features about MS and its treatment, but also about features about the virus. And that represents the perspective of how prevalent is infection in the community and what are the risks of the infection in different communities, basically. And we're seeing that playing out in different environments. So I think that's a very important first point. The second is that in the absence of evidence, we have to fall back on first principles to some extent, and Izan made that really important point as well. And the third is that we have to individualise. And I think that's very important that we as doctors cannot come up with carte blanche advice. We have to speak to our patients and we have to look at risks and benefits as best we judge them for each and every one of our patients, because there are different issues which percolate and they go beyond the fact that a person has a particular condition and even beyond the fact that they're on a given therapy, because different people are on the same therapy for different reasons and their circumstances differ. So I think one of the key messages out of today is that we have a mutual responsibility to up the ante in terms of our engagement between doctor and patient, basically. And there's no other way of approaching this. We can't put out sort of carte blanche advisories about do this or do that. I think that's one of the important messages.
Can we perhaps try to bring, and I appreciate everything that we say, that we're operating in evidence-free zone, at the same time we have the experience and expertise in using these therapies and also the knowledge of the biological background of how these treatments work in the organism. Can we perhaps try to think about what are the general notions?
Yeah, look.
Are there treatments that are more, that offer themselves more to changing the treatment regimens and perhaps delaying therapy? Are there treatments that we constantly put more on the safe side where we wouldn't be too worried about people staying on them in their present setting?
Yeah. I think there are, and this comes back to what I was saying in terms of having those mature, in-depth discussions with each and every person and to overlay these generic principles. But the generic principles shouldn't be used in isolation. They have to be used in the context in front of us. And let's just put another variable in front of this as well, because we know that MS is different for different people, and most people start with an overt inflammatory phase of the disease where we're concerned about the risk of relapses, whereas as the disease evolves, the risk of relapse per unit time decreases. And that's commensurate with increasing age as well. So as someone is older, the intrinsic risks of relapse related to MS reduce, but we know potentially the risks of COVID-19 for the general population increase. So there's that sort of element to it. In terms of the therapies, I think I'd just like to make one further important point, and that is that yes, there is always a risk of coming off therapy, but we as neurologists have to recognise there are circumstances where we are already advising that, and that relates in terms of planning for pregnancy, for example. And so we're already prepared to consider this risk versus benefit issue in terms of the risk of relapse versus the benefits of negotiating pregnancy without problems. And I think that's something to put into the equation, which I haven't heard of too much in terms of the discussions to date. And so that puts in context the degree of risk of relapse, perhaps for the general MS community, if that decision is being contemplated, basically. We do at times do that in relation to some of our patients for good reason. And that's where I come back to the individualisation of this. I agree in general with Azan in terms of the stratification she's provided. And I think we also have to think about the types of infections which occur with some of the therapies. As you correctly indicated, we don't have much information about this particular virus. It's a coronavirus, and it's a relative of SARS and MERS, which we've seen before, but those infections have been seen in very, very small numbers of people. So getting back to Thomas's perspective about numbers, we just don't have the evidence base in this group of viruses. But we do know that there is some risk in relation to some of the medications with regards to viruses. For example, we know that in relation to fingolimod with shingles and chickenpox. And so we've got to have that mature discussion with our patients about that particular issue, I think, for fingolimod. In terms of the B-cell therapies, I very much agree with you about this issue of risk versus benefit. And I think that patients, in all probability, are getting benefit for durations much longer than 6 months in relation to the dosing cycling of that particular agent. And we know that in the first 3 months after administration of ocrelizumab, there's a very profound reduction in total B-cell numbers to less than 2%, basically. So what I'm contemplating with individual patients at the moment, where there's an unknown in terms of the degree to which COVID-19 is going to be prevalent in our community, I'm contemplating delaying, basically, and saying, well, perhaps we shouldn't put you at the maximal risk in that first 3-month period post-ocrelizumab, and we've got a bit of time to wait and see what happens. And if this doesn't eventuate, as we hope it doesn't eventuate, we can then move into giving the next dose of ocrelizumab within a few months, basically.
And it is a really important point that you raised before, Trevor, that this is done in the context of the patient's disease severity. You would think differently about someone who previously, before their B-cell therapy, had very aggressive disease with lots of lesions on their brains and a number of relapses.
Absolutely.
In whom the B-cell therapy totally stabilized the disease and they had a very good biologic response to the therapy. And contrast that to someone who's got a quiescent disease that switched to ocrelizumab for a reason of safety or convenience, but whose disease previously wasn't very active.
Absolutely true. And I think another group to think about are the more mature patients who've been on therapy for some time, have moved perhaps in the last 5 years or so, to oral therapy for convenience, have not had any relapses for a long period of time, and are sort of in their 60s or even early 70s. Basically, I think we've got to have that mature discussion with them, particularly if their MRIs have been stable for a number of years, as to the risks versus benefits. Because independent of having MS, we know that being more mature in our community at the moment does set some increased risk. Above the age of 60, probably the risk is of significant bad outcome is over 1%. Over 80, it's getting into double digits basically. We're not going to have many patients, in their 80s on therapy, but in the 60s and 70s we may obviously have a significant number.
And I suppose we could use some of these same principles to other therapies that are given in a pulsed nature, such as Mavenclad or Cladribine, where we could possibly delay a second year's treatment in a similar way.
Indeed, and I think sort of once again, it's purely arbitrary in terms of the trialling of these agents as to whether those second and third doses were separated by 11 months. It could just as easily be 13 months or 14 months, I think, without any adverse effect.
So I think what we are all saying is that the risk of disease reactivation after people stop their therapies is present. It's a very real risk. It's a fairly frequent occurrence to see that people's disease bounces back, springs back to activity after they discontinue therapies. The role for us clinicians, together with our patients, is to work out what the individual probability in individual patients is, and then people in whom that risk will not outweigh the risk of COVID, and there are people in whom is a very clear-cut distinction and people should continue on their therapies presently.
Yes, and I think the last thing that we want to happen is that people stop treatments without consulting with their treating MS neurologist.
Absolutely.
Because that conversation and relationship is pivotal to not just their care during this time, but this is a lifelong disease that needs ongoing treatment.
Yeah, and what I've sort of learned in the last few weeks is that that's a mature discussion between patient and doctor. Each has a perspective, and ultimately the person themselves has a very important perspective on risk and benefit. And I had one of these situations recently whereby a more mature patient who I thought we could think about even stopping the therapy in that particular instance. Their perspective was, no, doctor, several years ago I had a bad relapse, and for me it's most important that I don't have another relapse, and the COVID-19 is an unknown. For me, I unequivocally want to keep on therapy, and that's the sort of discussion we've got to have and follow the patient's lead in relation to that as well, after they've been armed with the best information that we can convey.
Yes, and we do this often, as you say, with pregnancy planning and other times when we change therapies, and this is just another example of shared decision making.
Absolutely.
There was a question about PML. It has to be remembered COVID is not an immunotropic virus. It doesn't affect the way the immune system works in terms of weakening the immune system across the board as far as we know. So that means that the risk of developing a PML, which is a potential complication of treatment with natalizumab, one of the infusion therapies, we wouldn't expect it biologically to be increased by the COVID.
And nor do we think it is neurotropic either. We don't think it actually invades the central nervous system in any way, shape or form to our knowledge.
No, at the moment we have no evidence to support that.
So I guess moving on to one of the questions that we've had a lot, and I guess it's a question that many people, not just people living with MS, but many people in the community are talking about, is the notion of needing to self-isolate. And I think we've probably touched on a few of the things at the moment already in terms of it's going to need to be a decision on an individual basis. But in terms of general guidelines that we might be able to give to people living with MS about that, does it relate to how recently they might have had their last therapy? I guess you mentioned that, the sooner you've had that therapy, the more immunocompromised you are and things like that. Do we have any thoughts on that we can give to the people?
I think we can offset the answer to the question from Izan's introduction about the individual risk of contracting COVID in patients with MS, which we at the present time do not consider to be higher than the general population, set aside treatment of course.
Yes.
So in that context, everyone needs to self-isolate, and we see that across the board, worldwide, there is an escalation of these measures in different countries, and some countries come on board early, some countries come on board later. But it is very important that probably the most important thing that we can do, whether we do or we do not have MS, to contain the spread of the virus by minimizing the chance of its distribution within the population. The best way is there are several very palatable visual models of viral spread in populations. The best way is for us to limit our contact with other people who would be potentially susceptible, like everyone in the population, to contracting the virus.
Yes, limiting contact and good personal hygiene, they're the two obvious things. They've been the case in previous epidemics, whether it's been the Spanish flu or right back to the bubonic plague.
Oh yes.
Basically, exactly the same principles work.
I don't think that that applies to people with MS more or less than to anyone else in the population. Would you agree?
I absolutely do agree with you. However, I think coming back to Trevor's point that perhaps shortly after a course of therapy that may be more immunosuppressive, and by that I particularly mean someone who's had a recent course of alemtuzumab, might need to take some precautions in the months after. But outside of those special groups, I don't think that there's any change, and I think local authorities may have specific guidelines for at-risk groups, and those are what should be kept by and adhered to as they change.
We keep receiving on regular basis requests from people with MS to provide them with some sort of letter or evidence for the employer to justify their working from home, and we are in general very supportive of this arrangement. I think it's a simple measure that is being applied across the board in Australia, so there is no reason that people with MS shouldn't exercise the same caution.
I guess then a follow-up question to that some people have had is, are there any special precautions that they have to take when going into healthcare environments, when they're coming in for their treatments, coming in to have appointments? Is there anything in that environment that they need to be more careful about?
Look, I think that this is a general community perception about hospitals, and hospitals being a hotbed of infection, and that's not in general the case. Most people are in hospitals at this point of time for other reasons, and the risk in this environment at this point of time, in my opinion, is no greater than the general community risk. And I think that both as healthcare professionals and patients, we have obligations to make sure that that remains the case, so that we don't come to work if we're unwell. And patients also need to help us, help the community, by actually signalling whether they're unwell, rather than coming to hospital unwell with a febrile illness, whether that's to the outpatient department or to the infusion centre. We have ways of dealing with that, obviously, but by doing that, we're keeping people safe in those environments. That's the most important thing here, I think. And in general terms, we don't want people to get infusions when they're unwell anyway. So they shouldn't be coming to the environment if they're unwell. So I think that's my response. There is a perspective of the hospital being a place of unwellness, but it's not a place of unwellness with being a hotbed of COVID-19.
No, this is a community-acquired infection as opposed to a hospital
Exactly.
infection.
I like the quote, if I'm to quote the CEO of the Royal Melbourne Hospital, Christine Kilpatrick. It says, "No crisis should be wasted." I completely agree with this. And there are learning points for us from this present crisis and the COVID response. For example, we're putting in place more proactively alternative ways to interact with patients with MS. There is more across the board, probably in all hospitals in Australia now, more push towards using telehealth appointments or over-the-phone appointments. They are limiting in the sense that, for example, a neurologist cannot examine you during your appointment, but at the same time they're also limiting in terms of the human interaction, human contact, which is at the present a risk activity that carries some risk with it. At the same time, we're being highly selective. There are people who absolutely need to see their specialist, particularly if there is an issue that is percolating that needs to be attended to. But we would like to let you know that there are alternative approaches to appointments. There are some things that can't be replaced, like, for example, administration of therapy in a hospital or in an infusion unit that is well set up to deal with potential treatment-related emergencies, or things like physiotherapy where you need to see a person face-to-face. Of course, there are different situations.
I guess the other big question that we've had from a lot of people relates to the flu vaccine and pneumonia vaccine and what they should be doing in regards to those.
I think with the flu vaccine, it's very clear. It's business as usual. And in fact, we would like people to get the flu vaccine as early as possible. It's already trickling out into the community as of now. And I think what has become apparent from anecdotal evidence overseas is that it's actually possible to be co-infected with both COVID-19 and influenza, and that's not a good scenario. So for all of the reasons that we talked about previously, plus all of the reasons related to coronavirus, we want to minimise the impact of the flu, basically. And so if it was appropriate in the past, which it is for the majority of people with MS, it should be appropriate now for them to receive the flu vaccine. In terms of the pneumovax, basically, once again, it's same business as usual. In general, we target that to populations over the age of 65, unless there's a clear-cut perspective of immunosuppression associated with their treatment. And that's a small subset of people that we're talking about with multiple sclerosis.
Okay, well that was, so for people watching, we obviously had a lot of questions submitted beforehand, and we've tried to narrow those down for time into those groups, and we've sort of covered those. We've got a little bit of time left, and we're very mindful that we're not going to take up too much time. As was already mentioned, we're going to keep this to a pretty strict 45-minute time frame. We have had some questions submitted during it, so I might just run through a couple of those and we'll just keep them to very brief sort of answers, and we'll try and get through as many as we can just quickly. So Danielle has asked, will we be able to access treatment for relapses at hospital if needed? Home nursing has already shut.
I think that certain MS units have increased the use of oral therapies for relapses even before the COVID-19 crisis. And I think that is certainly something that can be considered in order to help people stay out of hospital. So instead of getting intravenous methylprednisolone, it can be given orally if your neurologist deems that to be an appropriate method of treatment. So there are certainly ways and means to get that, and I think all MS neurologists are committed to continuing to treat relapses and other MS-related issues as we always have been.
There are also escalation therapies for treatment of relapses. Not every relapse responds to the initial cause of methylprednisolone or steroid therapy. And in that case, we either increase the dose of steroids, or we can use other methods such as plasma exchange or a combination with more immunosuppressive therapies. And obviously, these are therapies that are higher level therapies and they require contact with the healthcare system. So in those instances, we wouldn't be able to keep people out of hospitals. But as Susanna said, the baseline is very amenable to adjustment or to utilization at home.
I think the other thing that we may also experience as all people with MS know, is that when you get any kind of viral illness, sometimes your MS symptoms flare. and that may not in fact be indicative of an MS relapse, but maybe a pseudo-relapse or some exacerbation of pre-existing symptoms due to having a temperature and some conduction blocks and myelin problems. So not everything may end up being an MS relapse.
I think that's a really important point you've just made, and that's part and parcel of, in the past, having an advantage in seeing someone and determining whether there's a urinary tract infection on board or something explaining the new neurological symptoms, and it's not an MS relapse. And in that situation, we balk at giving methylprednisolone. So that if we find in the near future we are deciding to treat more people in the community with oral methylprednisolone, which we could possibly be doing if, unfortunately, there are less people with COVID-19 having problems, and we hope we're not in that situation, but it's possible. We're going to have to be careful about liaising with our patients to make sure that there's good reason for them to receive the methylprednisolone, because we don't want to have them being put at disadvantage in being immunosuppressed with methylprednisolone in a circumstance where COVID-19 is sort of broadly throughout the community.
Exactly, so we would have to be circumspect about administering that drug in the first place.
That's right. Are you febrile? Do you have any other symptoms suggestive of a urinary tract infection, even though you might be feeling weaker? And that may serve as an impetus to be thinking about treating infection per se, rather than thinking about it being a relapse, because we have to get to the core of the presenting problem, that is the infection, in terms of adequate treatment of that.
So Philip has asked a question: how can we get tested for COVID-19 if we have symptoms and are in a higher risk group but have not travelled from overseas or have not knowingly come across someone with corona?
We have very clear testing criteria. Well, first of all, you would have seen there are a number of COVID-19 testing clinics or centres around the state, which there should be definitely one close to wherever you live in Victoria. They use a strict set of rules for indication criteria that serve as indication criteria for testing, and this is determined by the fact that the resource of the test kit is a limited resource, so we need to use it wisely. So the recommendation is that for patients who are febrile, so they have temperature above 38 degrees Celsius and have respiratory tract infections, they qualify for testing and should be tested. People who have respiratory tract infections, such as cough, sore throat, chest pain, as in cough type like of chest pain, and do not have increased temperature or do not have temperature above 38 degrees Celsius, but have some other significant risks, such as recent travel or having been in contact with someone who travelled recently or was diagnosed with COVID-19, those would also qualify for testing. Most other people who attend these centres, irrespective of their MS status and treatment status, would not be eligible for testing.
So Farah's asked, if we are diagnosed with COVID-19, do we stop treatment?
That's once again an evidence-free zone at this point of time, and I think the first thing to do is to discuss it with your doctor. In general terms, most people would be saying to remain on treatment if you're on daily therapy at that point of time. And it also comes back to the fact that the duration of effect of treatments are going to be such that even if you stopped it on that given day, you'd probably be recovered from the virus anyway by the time that the biologically effective half-life of the medication had disappeared. There may be specific instances where someone is doing badly, whereby we might stop the treatment basically, but that would be in the context of a hospital environment, I think. So I don't think patients should immediately think that they stop the treatment in any shape or form after being shown to be COVID-19 positive, but it would be an impetus for discussing the situation with the doctor and keeping the situation under surveillance.
There was also a follow-up question there as well about if the country was to go into lockdown, and obviously we're talking about hypotheticals at the moment that the government doesn't seem to suggest will be happening in the near future anyway, will patients still be able to access their neurologists during this time? This may be a question that we don't have an answer to, is my guess, but do we have any thoughts?
Well, the short answer is yes. And that comes back to Thomas's perspective about each and every one of us coming to terms with the idea of virtual communications beyond what we've done in the past, basically. Perhaps the medical profession has been a little bit, I'll use the word troglodytic or cave dwellers. We haven't been necessarily e-savvy as we should, nor have some of the healthcare providers. But I think people can be rest assured that we as a community are responding to this challenge and recognising that we've got to be more available rather than less. It's not business as usual, and quite rightly, everyone has a whole range of issues which need to be discussed, even if they're stable, because everyone understandably has some concerns about this situation. Hopefully those concerns won't be realised in terms of problems, but nevertheless one of our duties of care is to provide good advice and to reassure people that there is that connectivity such that if things do change, they've got the support they need.
If you think about the way that government manages emergencies, the emergency services do not get shut down, they actually get boosted. And healthcare is one of those critical emergency services, so we will be here in the case of lockdown.
Probably the last question that we'll get to. Michelle's asked, can you have the flu vaccine with Aubagio?
All vaccines are safe with Aubagio as long as they are not live vaccines. So the flu vaccine is safe with any of our MS therapies, as is the pneumococcal vaccine.
Okay, fantastic. All right, well, I mean, there's obviously going to be more questions flooding in, and apologies to people whose questions that we didn't necessarily get to today. We tried to cover as many as possible. I know that I speak on behalf of all of the MS community to thank the three of you for giving up your time today to participate in this. We had lots of fantastic comments saying how appreciative everyone is. I guess in the last minute or so, does anyone have sort of final words that they'd like to share with the MS community about the current situation and how people living with MS should be?
Oh, look, I think you've just said it in one word: community. And I think that, you know, we all recognise the community in general is challenged at the moment, and I think the more that we can work together as a community rather than as isolated individuals, everyone's going to come through this much, much better, basically. And that's independent of healthcare. It's just actually being there for each other, you know, an elderly relative nearby, those sorts of things, just to be out there to help, I think is good.
We all in this together.
Yeah, we're all in the same boat.
Okay. Well, thank you everyone who's participated. Thank you again to the three of you for participating. If you do have further questions as you watch this back, obviously a lot of people will be watching this back on replay. It will stay available on our Facebook page. Feel free to post comments and we will try and chase them up for you as well. But until then, thanks everyone and stay safe.